Good morning, good afternoon, good evening, and some of you, middle of the night. I'm very pleased to welcome you here to this important session of the IAS COVID-19 Prevention Conference. I'm Jen Cates. I'm with the Kaiser Family Foundation based in the United States. And I'm also a member of the Governing Council of the IAS. And we're just very, very pleased that you can all join us and be here for this discussion. This kicks off a session focused on policy and COVID-19. And the purpose of this session was to really capture the fact that policy, whether it's used in ways to promote access or promote and finding therapeutics, finding new vaccines, or promoting or allowing people to thrive, it can be an incredible asset. But as we've seen with COVID-19, it can also be an incredible barrier. So what we want to discuss today are that interface and how policy is shaping COVID-19 and some of the promising things that we hope can happen to help combat the pandemic, which is unfortunately not getting better fast enough. We have three people here today who can speak to different aspects of this, and I want to thank them in advance for taking time, because I know each of them are actually busy trying to combat the pandemic, and that is the most urgent thing. So the three that we have Seth Berkley, who is the CEO of Gavi, the Vaccine Alliance, and as probably many of you know, he's leading the effort on COVAX, the COVAX facility included, which is working to try to promote vaccine access around the world. We also are joined by Peter Sands, who's the executive director of the Global Fund to fight AIDS, TB, and malaria. And in addition to the work that the Global Fund is doing, the Global Fund and Peter pivoted immediately to try to be responsive to what was happening on the ground in the countries that the Global Fund works. And I should say Gavi did the same. And then finally, we have Fatima Hassan, who's the founder and the head of the Health Justice Initiative in South Africa, who is really looking at this from a health equity and justice and human rights perspective, and we'll lend that to our discussion. So I'm going to have each of them briefly talk from their vantage point, how they are seeing things right now, and then we'll go back and forth, and we look forward to taking your questions as they come in as well. Seth, thank you for being here.
Thanks, Jen. And let me start by saying I'll talk about vaccines, but I want to emphasize that what we need to do is make sure that there are therapeutics, diagnostics, and vaccines, and a health system for all of that. And I know Peter will talk more about those other areas. But on the vaccine side, let me just start by saying what extraordinary science we've seen. So, when we originally were talking about this, the earliest a vaccine had come before was 4 years, Ebola 5 years, many others much longer, 326 days, many efficacy trials, varying results. But I think what's really important is in those trials, no deaths in those vaccinated and really good responses against disease. So COVAX was formed, as you know, less than 3 months ago. It was declared itself open for business. We had 64 self-financing participants, and we are now ready to start delivering vaccines. We think in the first quarter we'll be able to get something in the range of 145 million doses. We've published our global forecast for the year, and this is to the 190 participants in the COVAX facility. So one of the important things is we tried to bring the whole world together in a multilateral mechanism and not just concentrate on the lowest income countries, although that is traditionally where we work. We have agreements with manufacturers for now more than 2 billion doses. And that's obviously important in terms of moving forward. But what's happening right now in 2021? So first of all, we need to continue to look to make sure we have more doses and more funding. We need to make sure that the regulatory approvals, we've tried to simplify that as going forward, that there is capacity to deliver these on the ground, that the cold chain is ready, the supply chain, delivery and logistics. These all need to be worked on. Countries are are at varying levels of readiness, but we need to make sure that that's able to move forward. And then I think we need to really think about manufacturers who have come to the table, have worked with tech transfers to bring access to more vaccines. But if manufacturers don't make their vaccines available globally at speed and at scale, the crisis is going to continue. So in this year, we're going to see the largest and most rapid global deployment of vaccine the world has ever seen. It is starting, should I say, somewhat chaotically everywhere in the world, but we expect that will get better soon. Healthcare workers, hopefully around the world, will get vaccinated early in the year. Later on the year, we'll see more expansion of activities, and I think that's going to be, what it's going to be about. Lastly, I'll just say that, of course, for us, the low and lower middle income countries are a critical component. We've expanded the numbers as part of our advanced market commitment from the normal 73 Gavi countries to 92 low and lower middle income countries and IDA eligible economies. We will need to raise additional money. Donors have been very generous, $6.5 billion so far. For this, we'll need at least another $2 billion to procure the doses that are there to make sure that we cover those at risk. And lastly, I'd say that we really have to work hard about the vaccine hesitancy and fear that exists in the world right now. Vaccines were moved quickly, but we didn't compromise on safety. I think that's really important, and we need to be working with communities around the world to make sure that people understand what's happened and that they have confidence in the overall effort. So maybe that's a good starter. Obviously, happy to answer questions about this, about some of the new variants that are there, about some of the challenges that we're seeing.
Thank you so much. Peter, to you.
Well, Seth has given a picture of the phenomenal work that's been going on the vaccine front, and I thought I could complement that by giving a bit of the broader picture of the global response, and then actually linking it back to HIV. The short message on the global response is that we need to be doing more and faster. When you're fighting a mutating virus, it doesn't work to go slow. We need both to accelerate the equitable deployment of vaccines in the way that COVAX is set up to do, but we also simultaneously need to be driving deployment of testing, PPE to protect frontline health workers, and therapeutics, including oxygen. If we don't take a concerted approach and only focus on vaccines, which unfortunately some are sort of only looking at, we run the risk, A, of flying blind because we're not doing enough testing in many parts of the world, and B, of actually losing a lot of lives before vaccines become sufficiently prevalent to actually protect people. And this will take time. It's a huge operation that Seth and colleagues are doing. So we need to step up provision of vaccines, tests, treatments, and vitally PPE to protect frontline health workers. Looking at this from an organization that's focused on HIV, TB, and malaria, we took the stance very early on that with the world being struck by a pandemic of this magnitude, we had to lean in. And we had to lean in and support countries for two reasons. One, because if we let the health systems become overwhelmed by COVID-19, HIV, TB, and malaria would suffer. And frankly, they have suffered, and we have been knocked back and off course on the three other diseases. But secondly, because we have, in the same way that Gavi is leveraging its capabilities and experience in vaccine deployment, we have a huge amount of experience of fighting infectious diseases, working with communities, deploying tests, treatment, and so on. We needed to leverage that. And so last year, in addition to the roughly $4 billion or so we deployed in fighting HIV, TB, and malaria, we mobilized another $1 billion, or 980 to be precise, to help countries in their COVID response. And roughly speaking, about half of that was spent on what you might call pure COVID response, things like tests and treatment, and the balance in actions to mitigate the impact on HIV, TB, and malaria programs and to do urgent fixes in health systems. But where we stand right now as Global Fund is we've spent that 980 million and we have no more. And so as part of the broader ACT Accelerator investment case, we are looking for more resources to support countries on the non-vaccine elements of the response and also on mitigating the knock-on impact. And just to close on the knock-on impact, if I think specifically around HIV, I think the HIV community in many places actually responded superbly to the challenges of COVID and came together, and there was enormous amount of imaginative and determined responses at all sorts of different levels as to how to avoid people's antiretroviral treatment being disrupted, how to support the most at risk key populations. A lot of things went wrong and a lot of things were knocked back, but some of the worst case scenarios for disruption weren't actually materialized. However, I think the thing that really concerns me now on the HIV front is prevention has been knocked more off course than treatment. And so we are even further behind on reducing infections than we should be. And we're also seeing that in treatment initiation, which is further off course. And so this year, we have a huge task in front of us. First, to play our part, complementing Seth and the vaccine side of the ACT response on the treatments and diagnostics and other aspects, the health systems aspects of it. And second, clawing back the ground that we've lost on HIV, TB, and malaria so that we were already off track, we're now further off track, but we need to get back on track. And I'd make the last point, which is, I think one of the really powerful things that many people have engaged with this year is the interaction between the things you do for one disease and the things you do for another. And the importance of testing simultaneously for, say, TB and COVID, the fact that we are leveraging molecular diagnostic devices put in place for viral load testing, for COVID testing. The fight against any one pathogen is integrally linked with the way we fight other pathogens. And we must both leverage that both to the advantage of the fight against COVID-19, but also, frankly, to the advantage of the fight against HIV. Over.
Thank you, Peter. Fatima, to you.
Thanks. So my comments are focusing more on vaccines, but obviously a lot of the principles I'm going to go through applies to the lack of access to sufficient supplies of PPE as well as diagnostic tests, particularly in the global south. So I think the good news, and I think Seth is right as well as Peter, is that we have some, unprecedented accelerated research into vaccines. We have a few effective vaccines, some at high efficacy levels, some slightly lower. The problem is we just can't access them in the global south, and we're not likely to access sufficient supplies in 2021, 2022, and some reports are now indicating even 2023. So, from the global south, we're really concerned that we're facing a massive global disaster and crisis. We are on the road to a worse disaster, and we need people to be ringing the alarm bells about that. There isn't enough political will, in our view, to get enough supplies to the global south rapidly. Because unfortunately, like we saw with HIV/AIDS, the world order has decided to prioritize intellectual property rights and protections and patent claims and price profiteering in a pandemic. I mean, even to the extent that since October, richer nations and pharmaceutical companies have actually been blocking the TRIPS waiver, which is, a request for a temporary waiver for the duration of the pandemic. So now we're faced with what we're calling vaccine global apartheid, as we witnessed in 2020, and some really pernicious forms of vaccine nationalism. And I'll come to the EU export ban later. So let me tell you about my country. In South Africa, we've got increasing hunger. We've got massive job losses as a result of the lockdowns. We've got a weakening health system, which Peter talked about, the interruption on ARV services. One of the largest ARV treatment in the world is at severe risk, including sexual reproductive health rights services and services for TB. But as of today, the 2nd of February 2021, not a single healthcare worker in our country has been vaccinated. They're likely to only get vaccinated in the next 2 weeks. The supplies only came in last night. Nobody else will be able to be vaccinated in the next few weeks because we're still waiting for supplies. So while young and healthier people and people who are not in the front line in other parts of the global north are being vaccinated, in some cases millions of dosages administered, not a single healthcare worker in my country who's holding the front line in both the public and private sector has been able to get a vaccine. And really for us, we believe that this is, due to self-created scarcity. It really didn't have to be this way, sort of a year into the declaration by the WHO of a public health emergency. And our concern really as health justice activists and people who are advocating for equity, and it's the same demands we made in the HIV/AIDS struggle back in the late 90s and early 2000s, is that the mechanisms that have now been set up, a lot of which are actually unelected structures, which undermine domestic oversight and regulation, do not address equity and supply blockages, and they're still relying on the volunteerism of drug companies without insisting on their explicit cooperation or even state measures and state action, particularly from the US government and the EU. So a number of countries are not using the measures available to it, even under the Doha Declaration, and we just find this inexplicable. It's the reason why activists from South Africa wrote on an urgent basis over the weekend to the Biden administration to now march in on the vaccines that it has co-developed, that it co-owns, and in particular Moderna, because we have a massive global South supply problem. So COVAX has, for example, said that about 27% of low-income country, most vulnerable populations could maybe access vaccines through that facility because richer nations actually bypassed COVAX and entered into bilaterals already last year, which Oxfam and Human Rights Watch had already warned about by September, October 20. And those contracts are for large amounts of supplies. South Africa is...
I think we can hear you on our panel. Okay. Sorry, Fatima, please go.
I'm sorry. So South Africa is being told, despite the hemorrhaging to our economy and the current crisis we're facing, that we're being treated as a middle-income country for many of these mechanisms. We have to self-finance our participation in COVAX, which means I, as a person from South Africa, is actually paying for vaccines, but I don't know the prices and I don't know the price assumptions behind those. So because of the bilaterals, because of the inability of COVAX to meet the demands of all low-income country vulnerable populations, the AU has now set up the African Vaccine Acquisition Task Team. It has to step in because of a number of supply constraints and because of the speed with which, or the lack of speed within which things were being done. So, and all of this is, I think, again, once again, in the context of artificial scarcity, and we're talking about a continent of 1.4 billion people. So it brings me to the supply problem and what we saw in the EU in the last 2 weeks, which unfortunately, the EU has responded with an export ban, which includes, for example, South Africa on the export ban list. Now, that may have been an error, then that error needs to be remedied immediately. But it's just inexplicable that we're now having to deal with another form of vaccine nationalism. First, it was around the supplies and the advanced market commitments. And now we're dealing with export bans, which, as you know, in the case of India, had to be reversed through quick diplomatic pressure between South Africa and India. It's the only reason why we were able to get the Serum Institute vaccines for our healthcare workers, which, like I said, will only be administered in the next 2 weeks. So also, I think the issue of transparency, and I'm coming to my last point, is that the COVAX mechanism, the EU pricing deals, the UK pricing deals, the US government, even the AU AVAT mechanism is not transparent. We as activists are struggling to get access to the agreements in a non-redacted form, in a non-redacted version. We don't have the price data. And all of these mechanisms are actually relying on public funding and public contributions, because in South Africa, the money for COVAX is actually coming from the national purse, the fiscus. the money for AVART for the AU is also coming from the public. There may be some contributions from corporates, but those corporates have also accumulated a lot of that, for example, MTN, because it has customers all across Africa. So I think there really has to be a reckoning around how do we ensure domestic price regulation. At the moment, our hands are tied because I'm not sure how I'm supposed to hold any of these institutions to account for the prices that we are being charged. And it also potentially undermines democratic institutions, for example, even in my country, because how does the Parliament of South Africa have oversight over COVAX or have oversight over AVART? And so I think these are important issues because it's certainly not the last pandemic we're going to be dealing with. And then I think the worst for me as an HIV/AIDS activist who had to fight for reducing the prices of ARVs, where we saw people die needlessly, where we saw people get sick needlessly, is that countries that could have taken measures to support the immediate scale up of manufacturing, to share the technology, to share the vaccine know-how, just for the pandemic, for a temporary period, just for certain COVID-19 diagnostics and vaccines and therapeutics, have actually blocked the TRIPS waiver, which to me is incredulous, given the scale of the global pandemic. And they're still blocking it. Today, civil society activists in South Africa have been going to different embassies from the EU and the US, have been asking them to reverse their opposition to the TRIPS waiver. And the US embassy has just called the police on South African activists who are trying to hand over a list of demands. So this is the situation we're dealing with in trying to demand transparency. So my final plea is that we need to course correct. I mean, we're definitely at a reckoning moment. I think both Seth and Peter have said, I've explained why with variants and mutations that are also now emerging in South Africa, no one is going to be safe in the whole world until everyone actually is vaccinated in a more widespread manner. Otherwise, immunity for the global community is going to be delayed for many years, and it's going to have such a significant impact, not just on our health systems, but on social cohesion, as well as the numbers of people who are getting sick and dying. Thank you.
Thank you. There's a lot that has come out already. I don't know if Seth or Peter want to respond. We only have 9 minutes left in our dialogue. But if either of you want to say anything or pick up from any of those points, please do. I also have a couple of questions that have come in. So while you're thinking about yeah, go ahead, Seth.
I mean, I share the passion, and I completely agree with the last point, which is we need to now be dealing with the new variants and thinking about that, because the whole world is not safe unless everyone is safe. That has been the start of where we are. I think we disagree a little bit on the tactics here, and I think for drugs and diagnostics, it may be that getting rid of the TRIPS arrangements and having patents freely available may be the solution. The critical issue for vaccines is know-how. So Fatima talked about the Serum Institute of India vaccine. Those vaccines were tech transferred from AstraZeneca and from Novavax, and actually we work to pay for those tech transfers. The other companies are also tech transferring vaccines and doing that. If one was to not have cooperation, one can have access to the intellectual property, but not the thousands of pages of know-how that allow you to rapidly scale up. And the amazing thing that's happened right now is, as problems in manufacturing have occurred, that has been discussed on a daily basis across the different manufacturers moving forward. That's been solved, and that's allowed this scale up, which has occurred in absolutely record time. So I agree with what she's saying about the passion. We should have had the money available ahead of time, which would have allowed better deals. I agree also about the vaccine nationalism as not being a healthy activity, but what we're trying to do is to get as many products manufactured as soon as we can around the world so that we can have global access. The last thing I'd say is that Fatima's right that we are saying now that we think we can get to 27%. We'd like to get higher than that. But I think what's important is we need to cover all the health workers. We need to cover all the at-risk groups. Right now, these are disease preventing vaccines, disease mitigation vaccines. We don't know whether they're transmission blocking vaccines. And so the critical thing is going to be to get those at-risk groups to protect the health system. And that's something that can happen fairly quickly. But I think it is a very important time. It's just the question is, how do we get there?
Thank you. Peter, do you want to jump in or?
Yeah, I mean, Fatima raises a lot of really important issues, which are really live and really critical right now. And they also point to the lessons we need to learn from the fight against HIV/AIDS for this fight here. One that is right in our face is the issue of equitable access. And although we're not doing it as well now as we should be doing, we are doing it a lot better than we did with antiretrovirals. When you think it took years to get antiretrovirals at scale to Africa and millions of people died, we should remind ourselves of that, because that's what's at stake here, and that's what underscores the passion about getting equitable access fast, is we cannot repeat what we did with antiretrovirals. A couple of other lessons I think are really important. One is that we sustain this until the job is done, because at the moment we're still at maybe the middle of the fight. But what we saw with HIV, and we saw it even more starkly with TB, is that actually the rich countries of the world, global leaders, sort of lost interest once it became less of a threat in the wealthier countries in the world. And I am really concerned that I'm really concerned about the issues we face right now, but I'm also really concerned that 12 months from now, we'll be in a situation where politics in many parts of the world are politics and the press are beginning to move on to other things, and yet the fight is still unfinished, and millions of people are at risk and dying in poorer parts of the world. So we need to sustain this and not end up with a residual pandemic in the way we did with HIV and TB. And then finally, and Fatima, I think, makes this point very effectively, and one of the things that we haven't had in the COVID response is the kind of civil society engagement that we have seen with such great impact in the HIV response. Most countries' COVID responses have been pretty top down, right? And haven't had such effective community engagement. I think as we move into the next phase of the response to the pandemic, we need to find better ways of mobilizing communities, because we know that you can only really beat a pathogen this formidable with a combination of the best science and community leadership and engagement.
Thank you. So believe it or not, I know, Fatima, I'll go to you next. We only have less than 3 minutes left. So I want to put one question out there, because we got it from a number of people, and then just let you each kind of wrap up with what you could say what you want. But I'm also very curious, even though this is a long game action, what in the next 3 months needs to happen from your view? The questions that we've gotten a number of questions about people living with HIV participating in or receiving the vaccine. COVID vaccines. And I did an advocates call yesterday. This came up repeatedly. So if any of you can just speak very briefly to what we know about the safety and efficacy of the current vaccines for people living with HIV. But I'll start with you, Fatima, so you can wrap up how you'd like to.
Thanks. So, I think it's a TRIPS waiver plus explicit cooperation plus the calling out of the conduct of companies. And I think we saw that with HIV/AIDS. Is when you threaten state measures or state licensing, you usually get some kind of voluntary sharing of technology transfer. And I think Moderna is a case in point. When this weekend we asked the US government to take certain action, we've now got unverified or unconfirmed reports, or in fact, according to the Deputy DG of Health in South Africa, that Moderna has actually in fact made an approach to the South African government, whereas a few months ago it said that it was not interested in entering any low-income country. And so I'm glad the Serum Institute example has been used, because I think what we're seeing is that there are limited sub-licensing. There are limited sub-licenses. I think there certainly needs to be more. When the EU faces supply shortage, we now have Sanofi, we now have Novartis in the mix making supplies for them. And I think that the problem with these sub-licensing agreements as well is that while there may be some cooperation in technology transfer, because there's no pricing transparency, we are paying more for the Serum Institute's AstraZeneca vaccine than what AstraZeneca has presumably charged the EU. But in the absence of sharing all of these different price lists, none of us are any the wiser. And my final point is that we have to accept, this is not about passion. This is not about me being an activist. And so, I just want to say nice words. We have to declare that the vaccine is a public good, because if you adopt that human rights legal framework where you treat it as a public good, a lot of these other measures will actually fall into place.
Okay, quickly, Peter and Seth.
I think, Seth, you're better placed than I to address the issue about safety and efficacy of vaccines for people who are positive with HIV. On my sort of work, look, there are lots of things we need, but one thing that would make a massive difference is if we could fully fund the ACT Accelerator across COVAX, diagnostics, treatments, and PPE. That would make a massive difference, because we could force through a lot of these issues about equitable access pretty quickly if we had the money.
Thank you.
And that's
Seth?
about 28 billion.
In terms of the efficacy, I know everybody feels like this is late stage. It's only been a couple of months since the first trials began, and we just heard about trial results over the last weekend. So far, there have been no safety issues in HIV-infected people, so that has not been a problem, but there has not been systematic reporting out of all of the vaccines and the subgroup analyses. There have been now some evidence in the most recent trial of Novavax. They showed a higher protection rate in South Africa against the strains that are predominant there, but a much lower response rate in those that are HIV infected. We need to understand that. We need to know if that's true across different vaccines so that recommendations can be made. And by the way, it isn't only that. There are questions on different age groups with the different vaccines, on different risk populations. And so those subgroup analyses, most of these trials have not been finished. There's emergency use authorization and interim results. Obviously, what we need to do is get that data before we can give the advice people need, but it is something that has to happen.
Thank you. We could obviously go on much longer, but thank you so much to all three of you. Peter, Seth, Fatima, I really appreciate you being here on behalf of IAS, and thank you. We're going to go on to our next panel. Bye-bye. Debbie, hello.
Hi.
Can you give me a sound check so I can see if I can hear you?
Yeah, it should be
Okay.
Working.
Great.
Perfect.
Great.
Nice to see you, Jen.
Okay. All right. So we just came out of a policy panel, and now I'm very pleased to introduce Debbie Sridhar, who's a professor and founding director of the Global Health Governance Program at the University of Edinburgh, and I would say a leading voice globally on COVID-19, and not just in the UK, although I know that's where you live, and you've been spending a lot of your waking and probably all of your hours on that, but also you've always been a leading voice on global health more generally and in HIV as well. And we're just really, really pleased to have you here. We only have 15 minutes, but we want to get from you your sense of how things are going. And this is part of a policy section of our COVID-19 prevention conference. So we're really trying to help share lessons learned about how policy is both facilitating but also inhibiting the response to COVID-19 around the world. So I'm going to turn it over to you, and thank you so much for being here.
Yeah, no, thanks for having me. I mean, it has been quite an incredible moment for those of us who have worked on health issues to suddenly have it be so pressing. And as well as usually your impact and research would take months or years, and now it's days and potentially even hours. But yeah, I mean, I think the two really interesting things to pick up on in COVID policy are first the tension between health policy and economic policy, which I know has been a real issue in the United States, but also in Europe, which is the idea of how do we balance these two, where we've actually learned that kind of COVID and non-COVID harms go together. Whereas if you have a large death toll, you seem to have economic pain as well. And the second thing is around what is an acceptable level of infection or an acceptable level of death, and can we put a number on it? And it seems like, in certain countries that have gone for elimination or for very low numbers, there's no acceptable level. Whereas other countries have tried to kind of treat it like flu and say, well, we have a certain number of people who die of flu and we don't shut down society. So is there an acceptable level of COVID? And that seems to have been the wrong way to pitch the problem, because we know it's completely different to flu and very infectious. And so I think in terms of reflecting globally on the debates in countries, those are the two things that seem to keep coming up in every single country. It's the economics versus the health. I know African countries as well have been debating this with their lockdowns, India as well, all countries. And then on the other side, what is an acceptable level of infection and how do you set that bar? And when you set it, what do you do when you constantly go over it, which is what happens?
Right. Thank you. Yes, I think that's such a good point, because we've seen that it's certainly playing out in the United States daily, but around the world. And one of the things that I think has not necessarily come through to policymakers is even in countries where the direct impact of COVID-19 on health-wise hasn't yet been as severe. The economic effect has been so strong. So if you want to talk to that, but the other thing, we've gotten a lot of questions about the new strains and how to think about this moment given the new strains, and does that really change our approach, or is it more about the speed of our approach, or both?
Yeah, so this virus it's the one that keeps giving. You think you have a handle on it, and I think 2021 is going to make 2020 look like a walk in the park in terms of the new variants and the challenges they present. We already have seen this in Scotland with a more transmissible strain, which is being called the Kent variation, Kent variant, which is, it's almost like, you have your restrictions and you're trying to race to stay ahead of a car, the virus, and we got a way to do that and to slow that car down. But now the car is going much faster because it's about 50% more transmissible. So our restrictions have to go so much farther to try to break it. And it seems it's really hard to break. We're stabilizing, but we're not seeing that crunch we saw. So I guess the overall view of variants in 2021 is this is going to be a rocky year, because this virus is finding ways to become more transmissible, and it's a selective advantage. It's like mutations are like a lottery, and obviously one that's more transmissible has a selective advantage. It's going to spread more. We are already seeing more severe health outcomes, more hospitalizations with this variant, potentially more deaths, is what they're reporting from England. But we're also seeing, and this is the worry about the South African and the Brazilian variants, potentially evading our immune response, meaning reinfecting people who have had the first version, and maybe our vaccines needing to have boosters to be able to adapt to the mutations. So there's no simple way out of this. And for me, the two things that come out clearly is suppression, that we have to continue to suppress, because the idea that we will all just have it once and we will reach herd immunity and then it will be over and whoever lives, lives, whoever dies, dies, doesn't seem to be right. It seems, well, from an ethical perspective, but also from a planning into the future, because we'll probably see waves of how this virus is mutating, because if we allow that kind of circulation, it's going to mutate to a form where we all get it again. And it's like never-ending cycle of but vaccines as well, having to have boosters. And I think the debate now in richer countries, I don't know if you're having this in the States, is so we vaccinating now our care homes, we're vaccinating health workers. So once we finish those, do we start vaccinating younger people, low risk groups, or do we start worrying about what's happening in other parts of the world and try to get vaccines out to all parts of the world? And that's a real tension of, do you try to reach herd immunity, 80 to 90% coverage through a vaccine in your home population, or do you go for the entire world?
Thanks. Actually, on that last point, that's, to me, is a huge issue. In the last panel discussion, we kind of got at that. I would say from the U.S. perspective, there's very little focus on the rest of the world right now. That's starting to change, but hopefully will change faster. But so two questions I have on the policy front that I know we've thought a lot about and talked a lot about. One is schools, and just how do I know you can't just look at one place and make a decision, but there's so much complexity around schools and reopening or closing. And the second is on vaccine rollout. Where I sit in the U.S., I've been focusing a lot on the challenges of vaccine rollout. And I'm curious from your, comparing that to how the UK has done thus far, just as two examples, lessons learned that UK is ahead of the US. So, just any thoughts on those two questions?
Yeah, so I'll start with the second one, vaccine rollouts, because in some way it's more straightforward here because we have a national health service, which means there is the infrastructure in place, which does flu vaccinations, GP clinics, and everyone is within the service. And there was prioritization done in a transparent way of who's at most clinical risk. And it's just been rolled out. And it seems the main issue has been supply and getting enough supply in.
I think we're hearing the other panel. Hold on, I think we're picking up on the next panel, so don't worry.
Okay,
1 second, Debbie.
I'll keep going.
Okay,
and the
keep
UK has
going.
also tried to do one dose instead of 12 weeks apart, rather than 2 doses 3 weeks apart to cover more people more quickly. So actually, I think it shows the benefits of having clear prioritization and having a national health service, because like in Scotland, I think it's over 10% of the population is already vaccinated. They're hoping probably all of us in the entire population could be done by the summer, early fall. On the other schools, it's an important day because today they're deciding when schools go back here in Scotland. And I think, the thing to say about schools is there's no easy answer, and the harms are massive to children and to working parents and so on. So I think I err on the side of we should be getting schools back as long as we can do it as safely as possible. And that for me means you're controlling transmission, which means you're not seeing exponential growth. You're seeing flattening and decreasing growth. So keeping restrictions in other areas. And the second thing is having a functional test, trace, isolate system. So when cases are picked up in schools, that testing is there, and then you can get the kids out quickly and isolating. So you don't end up with lots of kids, especially in high schools and stuff, becoming infected. But I think schools have become incredibly heated, and there's two camps. One which is like, oh, schools should be open no matter what. They're completely safe. And the other side, which is like, kids are super spreaders and vectors. And I actually don't think either are really true. I think in the middle, that we do see an age gradient. Younger kids transmit less than older kids. We know that clearly. We haven't seen many outbreaks in primary schools or in nurseries. We know secondary schools are trickier. And we also know there's mitigations we can put in place. But I think we have to get schools back. For me, it's unacceptable to have kids in Zoom school for months. We managed it in Scotland. So we got kids back in early August and full-time in-person education, and that ran till Christmas. And then the new variant came in, and this kind of messed everything up, talking about variants, because all of a sudden what we were doing before to suppress wasn't enough. So they had to accelerate it, especially with Christmas mixing. And then there was worry about, is the new variant more transmissible among children? And so could you be making policy based on old data when now we have a new situation? And so there's been some caution, but I think now in the next few weeks, the hope is to slowly start getting kids back in a staggered and controlled way. And we'll be watching, and this is also important in COVID, international lessons. So we're looking at Denmark, which has a new variant. They're opening schools this week, P1, 1st to 4th grade. So we'll be watching carefully to see, are they going to see clusters in schools? They didn't see it in the first round when they opened back in the spring. So I think the international learning is important too, because if they start seeing clusters in schools and they're getting alarmed, that should set off our alarms of something's happening with this new variant in schools, where if they open and everything is fine, then I feel quite comfortable saying, well, if we have similar prevalences, then why would things go very differently here?
Great points. I mean, this is playing out definitely in the United States right now. So one of the things that you said that I just want to pick up on, that I think it's so important, because this is moving so fast, and truly, I mean, those of us who come from an HIV background are used to having to think quickly and all that, but there's nothing like this, where policies that are being made today often are reflecting things that we knew yesterday, and that might not be quick enough. Can you just talk a little bit more about that? Because I think it's really important for people to understand that it's a challenging place to be trying to think about policy when so much of what we're learning is daily.
Exactly. And I think the way, having now worked very closely with politicians and ministers in different contexts, is there's 3 types of knowledge. And so the first things are things we definitely know, like facts. So we know how SARS-CoV-2 transmits. We understand the age gradient. We understand better who's clinically vulnerable. But I think if we take that out, this is the second category, which is things we think we know based on our expertise. So we think we know that schools are safe based on what happened earlier with the new variant. And then you have the third category, which is stuff we really just don't know. So I don't think we know how long vaccines will last immunity. I just think it's an open question. And I think when giving advice to politicians, it's important to differentiate which of the 3. and how much uncertainty and confidence you have in those. So do you have a lot of confidence in what you're saying? Do you have moderate? Do you have low confidence? And kind of where are you guesstimating based on your expertise? What do you actually know and what do you really don't know? Because I think people think science has all the answers always, where a lot of times we are just gathering it, and while we're gathering it, we're trying to assess it based on our expertise, and we're trying to kind of feed it into government. And inaction is also a decision, right? So waiting to collect evidence, this is the mistake I think Americans and British scientists have made, and I hold my hands up as well, like for example on face masks, as we were like, oh, we want to see the studies on face masks, and we want to see the studies on that, because we're used to having a strong evidence base, where actually sometimes waiting for the evidence is an act in itself, and you end up missing and moving quickly enough.
Very, very true. Believe it or not, we have less than a minute left for this session, and I could talk to you for many more hours about this. Do you want to, just one last wrap-up thought from you, and I guess what question, in the next 3 months, where are you putting most of your emphasis from a policy perspective? What do you think we all need to be focusing on, or at least in your part of the world focusing on right now?
So avoiding a third wave. And I think right now there is, again, complacency setting in, fatigue against restrictions, the idea the pandemic is over. It's not over. So it's how do we avoid a third wave in Europe, a third wave in the States. I think you had multiple going up. And also, how do we take a more global perspective, which is as we start to bring our domestic issue under control with vaccinations and restrictions, how do we start to think about other parts of the world, which, to be honest, we haven't been able to do so far because we've been so consumed domestically. So I think those are the two areas. I'm sorry, I've chosen two, which is getting past our situation, but also looking beyond that.
Yes. I'm hearing that we have another minute. Did I get another minute of your time?
Okay, sure.
Okay. All right. Because the panel we had before was on global access and financing. And I think that this is, for those of us like you, both of us who've worked for so long on global health issues and really our perspective historically has been on how to convince or work with politicians and donor capitals to care about people in the rest of the world. Now we're finally at a point where, I think what we've been trying to convey, that what happens somewhere else in the world affects us directly. It's very obvious to almost everybody at this point, yet vaccine nationalism and nationalism around we have to focus on our population first for a variety of reasons is setting in. So we're at this weird point where that lesson is much easier to see, but it's much harder to act on. And how are you starting to think about talking to politicians about this?
Well, I think it's coming back to self-interest. I mean, the point we're seeing now, and it's playing out right now today in the UK, is there's no point vaccinating everyone if you import a new strain from somewhere else, which your vaccines don't work against. And you go back to square one. And so in a way, I think it's in every country's self-interest to make sure this virus is suppressed everywhere else. And I think that's what we have to be communicating to publics, because there is now this push to vaccinate as much as possible. But a part of me is like, there's no point doing that if you're just going to have something else come in, which puts you all back to square one.
Right. Great. Okay. Again, thank you so much. You and I could have this conversation. We probably should for a lot longer. And thank you for everything you're doing, for taking some time today. We really appreciate it.
Perfect. Thanks for having me.
Okay. Bye.
Bye.
Okay. Yes. I can hold on, everyone watching. We're almost there.
I cannot hear anything.
Okay, so just so everyone knows, our last and final panel or discussion of this session is with Dr. Julia Marcus, who's an associate professor in the Department of Population Medicine at Harvard Medical School in the U.S., and also somebody who has long worked in HIV, and that's where I first knew her work from. And she is known for doing some pioneering work on harm reduction approaches and prevention. And during COVID-19 has become a leading voice on how to bring those lessons to all of us and to policymakers in this moment. She has written numerous articles for The Atlantic, so I encourage people who have not read those to look at those, because I think they are incredibly instructive and been important to the dialogue in the U.S. and beyond. And if we can get her to come in, we will get to hear her perspectives. Yes. So while we're waiting for her, I'm going to just let you know that we've gotten an incredible number of questions, some of which we've gotten to answer, but a couple that I'm just going to mention, and so that everyone knows what people are thinking about. One that came up in the first panel was, as we're investing in vaccine rollout, as well as therapeutic rollout and some of the things like the Global Fund is doing, how can we use those moments to strengthen health systems more broadly? And I think there's a lot that is happening there, but we're not necessarily capturing it. We also got several questions about how to convey the benefits of vaccinating the global south to the global north. Devi touched on that a little bit at the end, but I think that is going to be a really key challenge going forward for all of us. We did get a question about the involvement. I think we're going to get Julia in just a minute. So, okay. Can you see and hear me, Julia?
Yes.
Great. Welcome. Thank you for your patience. Hi, everyone. I had already been able to say that you were about to join us, and we were just working on video and audio. And so here you are. And again, Dr. Julia Marcus. And I was saying how I've known of your work for a long time on HIV. And during COVID-19, you've become a leading voice on how to think about, particularly for policymakers, a nuanced approach to this huge challenge that we're all experiencing, particularly focusing on harm reduction approaches and stigma, and how do we think about that? So since we don't have a lot of time, I'm just going to turn it over to you, and thank you for being here.
Yeah, thanks for having me. I'm really glad I made it on. It was a stressful 10 minutes. Yeah, so I've been kind of watching this all unfold through the lens of an HIV prevention researcher, and it felt to me like some of the ways we were approaching risk and risk taking, and both through messaging and policy, felt like the early days of AIDS. Like we were thinking about risk in a very binary way, as if things were either unsafe or safe, as opposed to thinking about a spectrum of risk along which people can make positive change. And also making this assumption that risk elimination is possible for everyone at all times, which of course is not the case. And thinking about, I felt like we were thinking about risk as a personal choice and risk taking as a personal failure, as opposed to thinking about the context in which people make decisions and the structural factors that drive their risk, and often the unmet needs that need to be addressed before they can reduce risk. And then finally, sort of following on from that, it felt to me like a lot of the messaging during the COVID pandemic, like the early days of AIDS, has been very shame and fear oriented. And that over time during HIV, we really learned why that approach can be counterproductive. And we're still dealing with stigma as a major barrier ending the HIV epidemic. And I felt like we had sort of forgotten that lesson, and we're going back to the shame and blame that I think come naturally from a place of fear and frustration, but tend to often be counterproductive as a public health strategy. So it seemed to me like a harm reduction framework, which we evolved toward during the HIV epidemic, hopefully, what I wanted to do was to sort of accelerate that process and try to get us there faster, really trying to think about more compassionate approaches to messaging and policies that address people's unmet needs and also acknowledge them and make them feel heard.
Thanks. So can you share some potential examples of where you've seen that's worked, maybe in response to some of the work you've done, or you've been able to highlight where it has worked? What's an example of
HIV or?
No, during COVID-19.
So during COVID.
Yeah. So yeah. Like what communities or country approaches or whatever are actually, in your view, working in this framework more than others, and how does that manifest?
Yeah, I think there are definitely positive examples, both in terms of messaging and in terms of actual policy. In terms of messaging, there have been examples of, I think especially, so if we take one example, masks, right? Like some of the early messaging on masks was not, there was a lot of like, you're a selfish bad person if you don't wear a mask. Look at these terrible people not wearing masks. And that was even coming from not just the public, but also health professionals and elected officials. And then I think we started to see some better messaging coming out of, for example, California, that had put together a series of videos And some of them were actually kind of fear-based, but they also did have some messaging that was much more compassionate, that really acknowledged that people don't want to do this, that even elected officials don't want to do it, but we kind of all need to do this, and we recognize the ways that this is challenging. We recognize the ways this impedes social connection, and we even acknowledge that some people feel like this threatens their masculinity, and rather than dismissing that, we're going to acknowledge it
Right.
and address it. So I felt like that was a much more positive example. There have been great examples from Canada. Dr. Bonnie Henry in British Columbia has taken a much more empathetic approach in her messaging. And then in terms of policies, we do see places where people's unmet needs are being addressed. And when I say unmet needs, I mean that broadly, everything from sort of basic survival needs, economic needs. And we see that in Vermont, that they've really taken an approach that supports people in isolating, that makes sure that they have, they have stipends to be able to stay home, that they have safe places to go isolate outside of the home. And also meeting people's social needs. And we've seen places where fire pits have been set up in parks, rather than saying you absolutely cannot see anyone outside of your household,
Right.
saying there's a safer place where you can do it.
Right. Yes. No. Unfortunately, I think we've seen far too many negative examples than those positive ones. Um, so, looking ahead a little bit, in the next 3 months, we're at this kind of critical point, 3 to 6 months, and in the U.S., but in many other countries where vaccine rollout is starting. At least it's underway in the U.S. and hopefully will be underway in other parts of the world, where it hasn't yet. Yet messaging is getting potentially harder, particularly around what does it mean when some people are going to be vaccinated, others aren't. How do you think about your risk? What are you starting to see or think about for helping people navigate this difficult space?
Yeah, it does sort of feel like things have gotten more complex rather than less complex.
Yeah.
And of course, vaccines are fantastic news, and I think we all need to be focused on uh, the fastest, most equitable vaccine rollout possible. But it does, I think, bring up a lot of sort of complexity for people, not just on a population level. How do we change our messaging, but also individuals in their everyday decision making around the ethics of taking a vaccine now if you're low risk, around how do I change my behavior? Can I change my behavior? And I think in terms of messaging, we need to stay focused on what's really important here, which is um, getting people vaccinated. And I think there has been a lot of messaging focused on the sort of pitfalls of vaccines, how they're imperfect,
Right.
and really trying to encourage people to not change their behavior after vaccination. And I worry that emphasis is a bit misguided. That in fact we do need to message that public spaces need to remain. We need precautions in public spaces until more people are vaccinated and infections wane. But for people who have been vaccinated, they really are going to experience a true reduction in risk. We need to communicate what that means, what the uncertainties are, and help them make informed decisions based on that.
Yes, I know earlier on in this pandemic, you helped develop a graphic for how people should think about their risk. This is pre-vaccine, so maybe you need to. Are you working on one for in the vaccine era to help people navigate this difficult time?
I'm not, but it's not a bad idea. I feel like it always helps to see that spectrum of risk, that it's not just safe or unsafe.
Right, right. Believe it or not, we only have a couple minutes left. One of the things that came up in so the first panel we had on policy was focusing broadly on financing and access globally and some of the barriers there. The second one was focused more on sort of government policies and how to sort of interact with policymakers and think about those. One of the issues that came up is that this is so fast moving that often the policies that we're thinking about today are reflecting older evidence or older knowledge. Can you comment a little bit on that in terms of COVID-19 and how we, I know for us on a daily basis, it's just we're trying to keep up as well. And how is that creating some new challenges? How do we keep as far ahead as we can?
That's a great question. It does feel like policy is often, there's a lag, right, between science and policy, and we have that always in in any field. But right now, because COVID is so sort of acute, it makes that lag particularly challenging. And I don't actually know how to speed that up. I mean, I think there I do hope that in terms of at least public health messaging in the US, that we are going to see a much shorter lag in terms of the CDC and what comes out of the CDC now with the new administration, that there will be, that some of that lag is political, right? Like that,
Right.
that hopefully that will shorten as there's less political involvement in public health. But it is a real challenge, I think, during a fast moving pandemic to have policy and science be moving as quickly as possible and in alignment.
Definitely. Just my last question, and really wrap it up however you'd like, because we're pretty much at the end. This new administration in the United States we believe, will be rolling out its own more aggressively its own campaigns around vaccines, but also more forcefully, hopefully, around what masking means and how to do it. What's your biggest advice to them as they undertake this? And then any closing thoughts you have around this whole issue around harm reduction, stigma, and going the path forward.
Yeah, I mean, I think that if I were going to ask for one thing in public health messaging and policy during the COVID pandemic, it would be more empathy, because I think empathy can guide both messaging that builds trust and can also guide interventions. So when we think about what is it that people need around masks, distancing, their ability to quarantine and isolate, and we come from a place of empathy, it might occur to us that we need to actually send good masks to people. It might occur to us that we need to make isolation as easy as possible. These policies that follow on from really putting ourselves in people's shoes and thinking about what it is that they need to make this easy, make this as easy as possible. So that's the one thing I would hope for.
Actually, I want to end on that, because I would love to end on the idea of empathy, because I do agree with you that is really an important fundamental aspect of how we can combat this pandemic and really any in the future. So thank you so much for being with us, spending some time today. Really appreciate it on behalf of the IAS, and thank you to everybody who's joined us.
Thanks a lot.